Welcome to the U.S. Environmental Protection Agency's webinar, Solving for the Indoor Environmental Determinants of Health and Asthma, Using Data to Prioritize In-Home IEDOH Interventions. Hello, my name is Dr. Mary Jo Errico, and I'm a scientist from EPA's Indoor Environments Division Center for Asthma in Schools, where we promote environmental asthma management as a critical component of comprehensive asthma care. Here you will see our agenda for today and what we'll be discussing. This is the first webinar in our new webinar series on solving for the indoor environmental determinants of health and asthma. We had about 600 registrants for the session, and our audience is from across the nation. This map shows the states represented in our audience today, with the white states having no participants registered and with a darker shading representing higher number of attendees. As we begin, I would like to ask everyone to please take a moment to participate in our Learning and Action poll. We want to have some idea of how knowledgeable you feel as you come into this discussion about using data to prioritize in-home interventions. We will repeat this poll at the end today to compare before and after to see if we are meeting our learning objectives. Thank you for participating. As you participate in the poll, I would also like to let you know before we begin today that we will be using the chat function in the webinar interface to collect your questions throughout the presentation. We will monitor the chat throughout the presentation to prepare a question and answer panel discussion at the end of the presentation. Please use the chat function throughout the discussion today to share your thoughts and questions for our speakers. Finally, we are recording today's session to make it available on AsthmaCommunityNetwork.org, and all participants other than our speakers will be muted throughout the session. All right, Pierce, can we see the results from that poll? Thank you, Pierce. So it looks like we have a good spread in our audience today. From very familiar about using data and analytics to not familiar at all, but it looks like most of you fall in that a little familiar or somewhat familiar, and that's great to see, and this is what we'll be discussing today. Again, I would like to welcome you to the first session in our three-part webinar series where US EPA's Indoor Environments Division, or IED, is sharing a solution that any community can adapt and apply to address and solve for its indoor environmental determinants of health, or IEDOH, to improve asthma outcomes. At IED, we build capacity with communities in environmental asthma management with the key drivers of high-performing asthma programs. That's what you see on the right. We have learned in our long-term mission to promote environmental asthma management as a standard of care that when cross-sector leaders and champions in a community commit to deliver asthma care through collaborations and partnerships that integrate community and clinic with strong ties to the populations most affected by asthma and a focus on addressing their care needs so that tailored environmental interventions can reach the people with asthma who need them most, asthma comes under control and high-quality asthma care results. IED has learned that when communities assemble these drivers, they deliver high-quality asthma care systems. We shine a spotlight on these communities so that all communities can learn from and adapt their own version of what works. As we have promoted this system, we notice its echo in the frameworks for the social determinants of health, or SDOH. We see that communities with systems for high-quality asthma care already have SDOH solutions, specifically IEDOH solutions. IEDOH are a subset of SDOH that co-vary with housing quality and access to medical care. They are modifiable environmental factors indoors, such as household air pollution, the presence of pests, mold and moisture, chemicals and irritants, among other indoor environmental stressors that influence risk and experience of chronic disease, including, of course, asthma. IEDOH are the factors that are the focus of tailored in-home environmental interventions, and they are what high-quality asthma care systems seek to address so that asthma health and quality of life outcomes can improve. When communities solve for IEDOH and asthma, they solve where housing, healthcare, and disparities intersect, an intersection where SDOH overlap and accumulate, especially for those in overburdened communities. Today, we will focus on one way to solve for the IEDOH and asthma, using data to prioritize in-home environmental interventions. We in IED recognize that using data and analytics is a strategy for systems change for asthma and will help communities deliver high-quality asthma care. We have increasingly realized the opportunity, innovation, and importance of not only spreading learning from communities who are using data and analytics to identify where their indoor environmental exposures are contributing most to local asthma burden, but also synthesizing this information to help communities across the country determine what assets they can garner at the community level to deliver multi-component interventions, particularly where the home environment is in focus. Our goal is to help build community capacity to use data and analytics to prioritize indoor environmental interventions and services to have the greatest impact on asthma health outcomes and disparities. We hope to provide communities the information and tools they need to gather and use data to focus their investments in the IEDOH. Some communities are already doing this, using a variety of data, analytics, and information to indicate where IEDOH are driving health burden. Today, we want to highlight a few examples of this work to showcase not only the broad range of data that can be used, but also the potential broad applications of these data to sharpen built environment investments by different sectors. As we begin this webinar, I would like to ground us in two key principles. First, data is everywhere and can help you tell the story of asthma in your community. Second, all data and analytics are valuable and can be used to prioritize services and affect change at the community level. What type of data you can collect may be dependent on your resources, including funding, time, and expertise. But any and all asthma or environmental data can be used to help address IEDOH to improve the indoor environments of people with asthma. And today we will hear three compelling stories from different perspectives that show these two key principles in action. We will start with a community-based organization who works at the hyperlocal level, specifically at the level of a public housing complex. We will hear how the community is not only impacted, but overwhelmed by IEDOH and the cumulative impacts of multiple environmental stressors. We will then step back to hear about research done at the city level and how data on asthma ED visits can be used to predict substandard housing before a failing score on a housing inspection. Finally, we will step back even further to hear about a county public health department's work on understanding environmental factors that affect different asthma ED rates throughout the county, and how their Healthy Homes program is using that information to prioritize communities for in-home environmental assessments and remediation. I invite you to listen to these stories, identify where you're at on the continuum of data collection and analysis, and be thinking about, what data could I collect? How could I use this data to affect change in my community? How could this data be used to prioritize indoor environmental interventions and services to maximize health outcomes? Who could I partner with to collect, analyze, and use this data to create the most impact? Today, we are focused on using data to prioritize IEDOH interventions to maximize impact on asthma health outcomes and disparities. Last year, we hosted a webinar series that introduced innovative strategies to address the IEDOH. And this year, we are continuing this work with the current three-part series on solving for IEDOH in asthma. We will build out resources related to these webinars on AsthmaCommunityNetwork.org. If you aren't yet a member, make sure to join so you will not miss these and many more resources. We have been building the Asthma Community Network since 2008, and there's a great deal to learn and find there. Our next webinar will also be announced on the Asthma Community Network, so if you're a member, you'll hear about it and have a chance to register. With that, I am honored to introduce our first set of speakers from the Red Hook Initiative in Red Hook, Brooklyn, New York. Carolyn Ferguson is a born and raised Brooklyn resident and the Environmental Justice Manager at Red Hook Initiative. Carolyn started at Red Hook Initiative in 2022 as the Sensor Lab Fellow and has been the fearless leader on RHI's journey of community science and air monitoring in Red Hook, Brooklyn. Carolyn oversees the Environmental Justice Program, which trains youth and community members in Red Hook on the science of air sensors and the importance of air quality. And this year we'll be expanding the work through a grant from the EPA. Carolyn believes every person has the right to clean air and is fighting for that right in Red Hook. Kara Smith leads the Red Hook Community Health Network, a partnership of community-based organizations, public housing residents, and healthcare partners who are committed to seeing equitable health outcomes for the neighborhood. Prior to joining the Red Hook Initiative team, she supported data analysis and policy development for collective impact initiatives in West Michigan and the South Bronx. Kara holds a Bachelor of Science in Social Work and Sociology from Calvin University and a Master of Social Work from Case Western Reserve University. With that, it's my privilege to turn the presentation over to Carolyn and Kara. Welcome.
Thanks so much, Mary Jo. Appreciate those introductions. And hello, everyone. Like Mary Jo said, my name is Kara Smith, and I'm here with my colleague, Carolyn Ferguson. And for the next 15 minutes or so, we're going to talk about how we've begun to understand asthma rates for individuals living in public housing in Red Hook, Brooklyn, and also talk about what we're doing with that data. So first and foremost, Carolyn and I work for the Red Hook Initiative, a community-based organization established in 2002, and we're dedicated to empowering youth, building community, and investing in residents. We focus on serving and working alongside residents of the Red Hook houses, which is Brooklyn's largest public housing population, around 10,000 residents in total. And for those of you wondering where in the world Red Hook is, perhaps this map will help orient you. So you're looking at a small portion of Eastern Brooklyn right now, with the tip of Manhattan at the top of the image. Red Hook is located here on the waterfront, and you might notice there's an expressway that is its eastern boundary. We'll talk about that expressway in just a little bit. So first, it's important to understand the environmental context of Red Hook. So these are the Red Hook houses that you see in the image. Like I said, it's Brooklyn's largest public housing development. And when we're wondering about asthma rates, this is the area we're talking about. We're really interested in public housing. A few years ago, we began to hear from clients coming into the office that their asthma was getting worse. And we even heard from ER doctors in nearby hospitals that more and more Red Hook patients were coming through with upper respiratory issues. So before I get into asthma data, let's just talk about some of the environmental factors our residents are dealing with. I'm going to take you through 6 main concerns. The first being mold and lead inside public housing. These buildings were built in the 1930s, and because of a lack of investment from the city, state, and federal governments, the infrastructure is beginning to crumble. And this gives way to persistent leaks and widespread mold. Hurricane Sandy devastated the houses in 2012, and as a result, the development is undergoing a mega construction project that will hopefully make the houses more resilient for future hurricane seasons. But for right now, the construction has been incredibly disruptive. And just to give you a picture of that, we had over 500 matured trees, which were uprooted, and dirt, which you can see in this photo, dirt which is tested positive for lead, blows freely across the campus. The construction started in 2017 and won't be completed until 2024. And speaking of lead, the houses happen to be located just north of an EPA Superfund site. So you see here ball fields 5 through 8 and ball field number 9. They were closed in 2015 for lead remediation work. And as mentioned before, the Brooklyn-Queens Expressway, also known as the BQE, cuts Red Hook off from the rest of Brooklyn. If you've driven through New York, chances are you've been on this expressway. It's pretty massive. And in the past year, we worked to understand concerns residents have around the BQE, and unsurprisingly, people were concerned about the impact pollution has on their breathing and overall health. Now, on the opposite side of the neighborhood, we have the Brooklyn Cruise Terminal. Each day, this cruise ship on your screen, each day the cruise ship docks at the port, it emits as much carbon into the atmosphere as 34,000 idling tractor trailers. And this is all extremely close to public housing. It's not a large neighborhood at all. And last but certainly not least, last mile warehouses have begun to open up. So these are Amazon, UPS. When you are on Amazon and you click 1-day delivery and you're living in Brooklyn or Manhattan, like this is where your goods are coming from. So these last mile warehouses expanded into the neighborhood and of course are bringing along increased truck and car traffic. So residents are aware of these environmental factors, which are likely impacting their health. And we as a community-based organization are hearing residents talk about their asthma and upper respiratory conditions getting worse. This nudged us to begin to want to understand what data sources can tell us about asthma rates. Unfortunately, there are a number of challenges with most data sets we look at. So Red Hook shares a zip code with the community district, or it shares a zip code and is a part of a community district with a number of wealthier neighborhoods, which tend to have greater access to resources. And even in our own neighborhood, Red Hook, there are incredibly large disparities within health outcomes for individuals living in private versus public housing. And then we're also grappling with the reality that things are just changing quickly and data tends to lag. The impact last mile warehouses are having on the community won't show up in 2020 data. This is a new issue for the neighborhood. So we want to have data points that are representative of the really rapid changes we're seeing. So let's talk about a little bit of what's worked for us. The good news is that census tract level data is really helpful because census tract 85 is the entirety of the Red Hook houses. However, the caveat here is that we know the total population of public housing residents in Red Hook is widely underrepresented. On the books, there are around 6,500 residents in Red Hook houses. Our better estimate is that there are 10,000 residents. And so you'll see on this map in the top left corner of the image that census tract data would clearly give us a better understanding of health outcomes for our residents compared to the other 4 tabulated areas. And these other 4 tabulated areas are common of what we see in other data sets that don't include census tract. So we've relied on sources from the CDC, census, even the EPA to get an idea of what's happening with asthma on the census tract level in order to understand our situation better. We've also turned to grassroots data collection in order to capture some of the nuances that are often overlooked. So these are just 3 examples of community-based data collection and reporting we've done in the community to understand not only has asthma is showing up and impacting residents, but also how other chronic health conditions have impacted public housing residents. When we look at census tract level data, we usually see around 14% of adults in Red Hook houses have asthma. Grassroots data collection suggests that number is closer to 25%. And we see about 50% of residents saying asthma is the top health concern in the neighborhood. And so what we've begun to do with some of the data we're collecting from, grassroots data, census data, and frankly, anecdotal conversations with residents and physicians in the community is, well, a handful of things, and we're going to get to that. So first, last year, we were able to provide air purifiers to 50 households experiencing mold and asthma. Right now, we're working with the Housing Authority on a proposal that would provide every apartment unit with an air purifier in each bedroom and living space, which is really exciting. We've also ventured into doing some community air monitoring work, which I'm really excited for you all to hear about. I am going to turn it over to my colleague, Carolyn, who oversees that work.
Thank you, Kara. This first photo right here is in front of Red Hook Initiative, and it's informing the community and pacifiers of 3 things. And those 3 things are: 1, we are continuously monitoring the air quality in Red Hook. 2, that they can scan the QR code and get real-time air quality data. And thirdly, there's a color-coded chart to help people determine what the air quality is for that particular day. Okay. So community air monitoring, as a combination of strategically placed air sensors, the air sensing network in Red Hook also includes traffic counting sensors to monitor the influx of trucks and delivery vehicles due to last mile warehouses. A major part of the community air monitoring network is having input from the community members, because they have firsthand knowledge about the environmental stressors in their respective communities. They also have come from various professions and skill types. Like some people work with soil, others work with water, other professions include artists, scientists, data analysis, and they usually have affiliations with other organizations or CBOs, which is very helpful in allowing for community science. It's like which allows for educated hypothesis to take center stage in creating the community air sensor network. Okay. Engaging the community with one. Oh, I'm sorry, I'm nervous. So how do we do it? So we do this by engaging the community with one-page information flyers, community lunches, sips and paints, and tabling events. These all lead to open conversation where people do not have to feel pressured into thinking there's a right or wrong answer. I also find it much easier to retain information from the community when we're just engaging in conversation. And it's easier to get people to open up to do surveys when you just have a conversation and they don't feel pressured to think there's a right or wrong answer to what's being asked. And sometimes incentives help also. So secondly, so that's how we get the information from the community members of where they may think the likely hot spots that are impacting the air quality in their community. And then to verify that over the summer, based on their responses, we created a scavenger hunt of those named hotspots for our summer camp middle schoolers who are recently learning about particulate matter 2.5. So we did this twice a week for 4 weeks using the AirBeam 3 mobile sensor, and then we charted and compared the readings to the purple air sensor data and confirmed our findings with the DEC sensors and the EPA Air Now app. And sometimes the assumptions of where the sensors where the community members thought the census should go was not always feasible, and that's because The sensors that we were using only monitor for particulate matter. So 2.5, it wasn't monitoring for like greenhouse gases or ozone 3. So in those cases, it wouldn't make sense to do that. So the other the other thing we would do is identify current air monitoring initiatives that's already being done in the community by other CBOs or private citizens. Like for example, we do have a private citizen that monitors the trucks, the traffic, and they use a sensor called Luna. So that's one way that we do that as a collaboration. The other thing is that we find out what the other people are doing, like if they're monitoring for carbon, green gases, ozone 3, and like why are they monitoring for those things? Like was there an increase in those particular pollutants? Was there a decrease in those particular pollutants? Like what is the why behind their air monitoring initiatives, and how we could possibly collaborate with them in the air monitoring initiative. And sometimes the collaboration could be through in-kind working groups, sharing in grants, sharing data, um, and so forth. So now, also, I'm sorry, the purpose of the purple air sensors and positioning the purple air sensors in proximity to the air quality sensors where there's little or no air monitoring initiatives exist, where no air monitoring initiatives exist. So throughout Red Hook, there's a lot of air monitoring happening, as I mentioned. However, there's no air monitoring happening directly in the Red Hook houses. So, so there's no air monitoring happening right inside the Red Hook houses. So we saw that a good place to start would be inside the Red Hook sensors. And one way to do that is we would be using DIY sensors inside different residence apartments to monitor the air quality for particulate matter, because we know that particulate matter can come from using a gas stove, smoke, soot, any one of those things. So that's one way, but our main goal is to do the outdoor air quality, and we'll be doing that with AQ mesh sensors. Yeah, and that's the last slide. Okay, so finally, building the community advisory group. So at RHI, we will launch a community advisory group in the spring of 2024 to analyze the data and produce recommendations for local mitigation based on the findings. When report recommendations are finalized by spring 2025, RHI and advisory group members will present findings and recommendations to key stakeholders and policymakers at the city, state, and federal level. The data collected through monitoring with the AQ mesh sensors, as well as the quarterly reports and recommendations, will continue to be available publicly through RHI's website and our platform at www.redhookhub.org. Thank you, and now I pass it back to Mary Jo.
Thank you, Carolyn and Kara. It's so inspiring to hear how you've used a variety of different methods and data sources to try to understand asthma rates and air quality in your community. Thank you for sharing. Now I am honored to introduce our next set of speakers who conducted research in New Haven, Connecticut. Dr. Adam Haber received his PhD in computer science from the University of New South Wales in Australia, where he developed machine learning algorithms for autonomous rescue robots. During his postdoc at the Broad Institute in Boston, he developed and applied new algorithms for the analysis of genomic data. These studies were focused on the airway epithelium and helped discover several new types of lung cells, which are now implicated in the pathophysiology of cystic fibrosis and asthma. In 2020, he started his lab at the Harvard T.H. Chan School of Public Health, which focuses on the application of machine learning and data science to understand asthma at cellular and population levels. Dr. Elizabeth Samuels is an emergency medicine physician, health services trained researcher, and associate professor of emergency medicine at UCLA. She completed her emergency medicine training at the Brown Emergency Medicine Residency Program, a health service research and health policy fellowship at the Yale National Clinician Scholars Program, and is board certified in emergency medicine and addiction medicine. Her work focuses on implementation and evaluation of emergency department-based health equity initiative. Welcome, Adam and Liz.
Thank you so much, Mary Jo. Thanks so much for having us today. We're very excited to share our work. Adam's and my work is a little bit more abstract than the amazing community-based work we just heard about, but I think is applicable in terms of a proof of concept that could be used to support the or part of the amazing work that we just heard about with the prior presenters. So everything we're going to present today is from a research study that Adam and I worked on for several years when I was previously living in New Haven, and then afterwards. And then we can put a link in the chat for the link to the actual paper. But some of this, I think we already know. We talked a little bit about today in the introduction, and it's going to be a thread throughout all of the presentations. We know that poor quality housing increases asthma incidence and exacerbations due to asthma, and morbidity and mortality due to asthma. I think what Adam and I, what kind of drove us in our research is there a way we can leverage data to more expeditiously identify poor quality housing that can then be remediated? We know that residents who live in poor quality housing have higher emergency department visits for asthma. As an emergency clinician, we see this all of the time. I'm not surprised that the folks in Red Hook were hearing this from healthcare providers. It's a very sensitive, in my opinion, indicator of what's happening in the home. We know that when we improve housing conditions, emergency department visits for asthma can be reduced. But it is, often the identification and remediation of poor housing conditions is incredibly delayed. In public housing and in renter-occupied housing, the burden of both identifying and calling attention to those housing conditions falls on the tenant themselves. HUD inspections, do occur, but they occur on an average about every 760 days, and even less frequently for subsidized housing. There are differential exposures based off of income and race that produce inequities in asthma outcomes and asthma incidence. So some of these are about neighborhoods. We've talked a little bit about some of these today. Some of them are structural in terms of where people are, where the neighborhood is located, the physical conditions of the actual buildings people are residing in, and then the resources available to individuals for both self-advocacy and also to remediate those conditions and address those environmental exposures. People have differential exposure to toxins, and then they have differential access to healthcare and preventative resources. These produce both race and class inequities in both childhood asthma and then long-term outcomes for those individuals. So, as a researcher and as a clinician, I think my question was, and the question that Adam and I shared was, could you, if we know emergency department visits go up when people have asthma and that poor housing conditions result in increased emergency department visits for asthma, could you use emergency department visits to identify poor quality housing? Could we use these data, which are already collected, to more proactively identify poor quality housing?
Thanks, Liz. So our goal for this study was therefore to set up a machine learning model or a statistical approach that integrated as its primary outcome as Liz was saying, asthma exacerbation data, but also looking at other data sources to see whether we could accurately identify which buildings in a city at very high spatial resolution really had these bad indoor conditions. So what we did was we performed a retrospective cohort study in New Haven, Connecticut, and that's hopefully going to be available as a link, and I encourage you all to take a look at the study. But a retrospective cohort study just means we looked at data which had already happened. So by that, we looked at the electronic healthcare record from Yale New Haven Hospital, and we basically downloaded all of the asthma ED visits from 2013 to 2017. And part of the motivation, aside from the fact that Liz was living there, for choosing Yale New Haven Hospital was that it's the only emergency department serving the New Haven city. And so that means that a high proportion of the people who have an asthma attack will show up in that electronic health record. The only data source that we had to really validate the presence of bad housing conditions is these REAC public housing inspection scores, which some of you, or perhaps many of you, have already heard about. And these are publicly available data that give a validated metric between 0 indicating bad conditions or horrible conditions and 100 indicating perfect conditions. And those are carried out at semi-regular intervals for all public and federally subsidized housing. We also used census data from the 5-year estimates of the American Community Survey to get information on neighborhood demographics, things like race, ethnicity, and median household income. And then we geocoded these data and mapped and linked them at the parcel level. So I'm going to say parcels a lot, but that just means individual buildings. And we linked the emergency department visits to REAC inspection scores. And this map that you can see here is a visualization of where our emergency department visits were happening across New Haven. We've sort of moved the points around very slightly to protect patient privacy, but you can definitely see that there are some hotspots. But of course, we really wanted to go beyond thinking about neighborhood hotspots and think about computing asthma incidents at the building level or at the parcel level. And so one of the first things we really realized is that there are two distinct signals. There's the unique number of patients who show up in the emergency department, or there's the number of visits. And at the population level, those two are similar. But for an individual building, we wanted to be able to distinguish between seeing, for example, one patient who shows up 15 times versus 15 unique patients who show up one time each. And the first case is more likely to be associated with severe disease, whereas the second case is a stronger indicator of bad conditions at that building. So we developed a hybrid statistical approach to take into account both the number of patients and the number of visits. And if people have questions about that, I encourage them to read the paper, or perhaps we can talk about it in the panel discussion. Our main outcome was Pearson's correlation, and we really wanted to see whether an incidence rate that we compute at the building level was actually associated or statistically associated with these REAC scores. On the right-hand side, you can see a map of what these incidence rates look like across this central New Haven. What should be really obvious is that a lot of these, each one of these delineated areas is a parcel or an individual building. A lot of them are gray, which indicates that we're either unable to compute an incidence rate at that building because we don't see anyone from the showing up in the emergency room, or we have not shown it even though we could calculate it just to protect patient privacy. I'm only showing buildings here where there were more than 5 people just to protect privacy. So this is going to be a theme for this method. It really, it's highly specific, but it's not very sensitive. So in a lot of cases, most people, for example, never have an asthma attack. So we're not able to estimate risk at every building in the city, but where we are able to, you can see that there's quite a lot of variability in the different colors. So going back to the bullet points on the left, we then took these incidence rates that we computed at the building level and adjusted them using a linear model and a nonlinear model for the different demographics of the patients, both at the individual level and where each building is located in a particular neighborhood. We also took a sliding window approach to see not just do these scores predict housing conditions across the entire study period, but do they give us an advance warning in advance of a failed housing inspection. So these scatter plots show some of the results. Each point here is a parcel or a building, and the y-axis is our building level incidence rate of emergency department visits for asthma, which takes into account both the number of visits and the number of unique patients. On the x-axis, we can see housing quality, which is the minimum REAC inspection score. So that's the worst score that each building got over the study period. And one of the things that should be obvious is that there's only about 60 points here, whereas of course there are thousands of buildings in New Haven. So we're unable to inspect the relationship between our incidence rates and actual housing quality as measured by the REAC score for most buildings. But for the federally subsidized housing, which is these 60 complexes, we can actually validate our estimates. And what we saw, and what I hope is obvious here, is that there's a strong and statistically significant negative correlation between these two variables, which indicates that the buildings that have the highest parcel level asthma visits in the top left-hand corner also have the lowest HUD inspection scores. So this really showed us that computing incidence rates at the building level does give you an accurate prediction of housing quality as measured by REAC scores. The other thing I want to point out is that these three buildings that are colored in red have since been demolished after outcry from their tenants due to bad conditions. While that's a horrible outcome, it gave us confidence that the model is predicting what it should. And here in B and C, we've adjusted our estimates for individual patient demographics and also neighborhood demographics. And you can see that the slope of the line is reduced, but the p-value remains significant even after this more sophisticated nonlinear correction. And we could talk about this in the panel discussion about whether we think it's a good idea to actually adjust for incidence. It may actually not be. But basically here we concluded that we do have a signal that can detect poor quality housing. We then turn to look at the temporal relationship. And to do this, we use this sliding window approach. And this is actually a very simple idea. We basically took for each time point in the data, we look only at a fixed window before it and count only emergency departments that happen in that window. And we use a 12-month window. So you can hear the x-axis is just time. And you can notice that our estimates begin in March 2014, which is 1 year after our data actually begins. And so at each point, we can count the number of ED visits in the preceding window to see what's happening at this particular complex, which is just an example, complex D1. It's a large apartment complex with 140 units. And we saw 14 emergency department visits over the study period. So the y-axis here is just the number of unique patients showing up in the ED in each window. And so here, this dotted line indicates what we would expect to see given an apartment complex of this size. So for 140 units, we do expect to see about 3.5 emergency department visits in the year. And in this case, what we're seeing is approximately consistent with that or even a little bit less. And this building was inspected twice over the study period. Its two REAC scores are indicated with these blue lines, once in 2013 and once in 2016, and they both got pretty good scores. So this is an example of a building where everything's looking okay. By contrast, here's complex A, which is actually had a similar situation to Red Hook, where emergency department physicians were observing a lot of people coming in from that complex, and that was actually what motivated us to do this study. And as you can see, whilst this is a bigger complex with 204 units, and so it has a higher expected rate, we would expect to see 5 patients each year. We're seeing far more than that, over 15 and up to 20 in some 1-year windows. And if we look at the computed incidence rate, so sorry, I didn't mention this, but the blue line indicates the 90th percentile of all buildings across the city, and the red line indicates the 95th percentile. So these dots being above these lines indicates that these incidence rates at this particular building are much higher than anywhere else in the city, or certainly higher than the 95th percentile. And being up this high, we actually showed in the previous plot, this is the worst building in the city. And by the time it actually failed its REAC inspection in mid-2015, the emergency department visits had been elevated for almost 2 years. And when we took an average of how far in advance we get a warning before a failed inspection across all buildings, we found that it was about 1 year in advance. So not only can looking at these incidence rates accurately predict the presence of poor quality housing, but they can do so years in advance of a failed HUD inspection. So with that, I'll turn back to Liz.
So how do you translate this into practice? And this is a proof of concept, right? So Complex A that Adam mentioned, which was a public housing complex in New Haven and now is no longer. You can see the pictures of the complex and then what the lot looked like in 2019. What we would hope, or what we advocate for, is that you can use electronic health record data. It's a feasible source of data to identify unhealthy housing. This is data that is already collected. It does not need to be newly collected, excuse me. I mean, I'm not saying that integrating data sources from multiple health departments or utilizing health data or mapping is necessarily easy, but it is something we can do to try to direct home inspections at sites of greater need, to reduce onus of reporting on people residing in unhealthy buildings, to hold landlords accountable for maintaining high quality places, safe and healthy places where people can live, and improve the conditions in public and renter occupied housing. Ultimately, improving conditions in housing will improve individual and population health outcomes. So proactive inspections, which is what we would hope a model like this could be developed into or translated into, can be used to repair unhealthy housing. There are generally 4 groups of people who influence and support repairing unhealthy housing. The person who owns the building, right? Tenants who organize and advocate for themselves to get unhealthy housing or damaged housing repaired. Government at city, county, state, federal levels, they influence whether and how unhealthy housing is repaired. And then community organizations. This includes groups like the group in Red Hook, which we just heard about, but also tenant organizations, environmental justice organization, housing advocates, and voters. There are many housing measures and bills that are put forward at local and state levels every year. And that can be leveraged to try to maintain high quality and healthy housing for both renters and also specifically for people who reside in public housing. I think that leveraging that and leveraging these data can really support tenants, specifically those who are marginalized and who are disproportionately likely to live in poor quality housing, do fear retaliation for reporting unhealthy housing conditions and loss of housing, which is particularly important in large cities where the cost of housing is so large and homelessness is on the rise. And there is, I think, unfortunately, we do know there is unequal housing code enforcement when things are reported. And then, I think the fear of retaliation in particular for repairs to get made when maintenance of housing and cost of is so tenuous and cost of housing is so extreme, particularly in urban centers. So Adam alluded to some of this when he was talking about the results. This model is really much better for large buildings. It is less useful for smaller buildings or buildings with a fewer number of tenants. So that is a limitation on the model. So really, this is for high density housing parcels that have a number of units. We really need to do further validation. This was a closed health system with one electronic health record. They were the only emergency care system for the surrounding area. There are different challenges if you're trying to integrate data sources from multiple health systems and health systems with multiple hospitals. Privacy is very important here. I think particularly low-income communities and communities of color do experience disproportionate surveillance from multiple aspects of government, and individuals want to have their privacy maintained. So implementation and how this is implemented needs to keep this in mind to try not to increase this undue burden on communities. While the intent may be to take onus off of them, there's a risk for unintended consequences of increasing of surveillance on those individuals. So that's an important consideration to be made. And then just trying to, however implementation is set up, doing that in a community engaged process to try to reduce any kind of risk of stigmatization and surveillance in those communities. So just a few take-home points, and then I look forward to the next presentation. So electronic health records are a feasible data source to identify unhealthy housing. It is accurate. It can accurately identify them. It can identify unhealthy housing with a significant lead time earlier than current surveillance and identification mechanisms that are currently used. Tenants face bad conditions and they need supporting data to both identify the unhealthy housing and support remediation of unhealthy housing, and really need to, in the future, in actual applications, engage community to inform implementation, reduce stigmatization, and maintenance of individual level privacy. We're happy to take any questions. These are our email addresses. We also can discuss further in the panel discussion. And thank you so much for having us today.
Thank you, Adam and Liz. That was an excellent presentation. I love how you looking beyond your research and thinking about, how you could use this type of data analysis to affect real change. So thank you. That was excellent. With that, I am honored to introduce our final speaker from the St. Louis County Department of Public Health in Missouri. Ellen Huddy is an epidemiologist at the St. Louis County Department of Public Health. She's been with St. Louis County for 2 years, and her work focuses on chronic diseases with an emphasis on maternal and child health, respiratory diseases, and environmental health. Ellen is passionate about health equity and working towards a better St. Louis community for all. She received a bachelor's degree in public health and psychology from St. Louis University and a Master of Public Health degree with a specialization in epidemiology and biostatistics from Washington University in St. Louis. Welcome, Ellen.
All right, thank you. Thanks, Mary Jo. I'm excited to be here today and share a little bit about my work. As was mentioned, I'm an epidemiologist at the St. Louis County Department of Public Health. And today I'll just be sharing a little bit about my work on asthma surveillance and how we were able to use these data within this department. So first, I'm going to share a little bit of context, some about our community and the program that I work for. Next, I will review my approach to asthma surveillance and share some findings from the most recent report. And then finally, I'll discuss how these data were used and some next steps for our asthma work. So to give you some context and idea of where I'm coming from, I work in St. Louis County, Missouri. Our county is located on the eastern side of the state next to the Illinois border. It's right along the Missouri and Mississippi rivers. So you can see it's highlighted in red here on the map. And then zooming into our region. So St. Louis County is the largest county in Missouri with about 990,000 residents. And one thing to note is that we are separate from the city of St. Louis, which is an independent city with their own government and health department. So this presentation will focus on St. Louis County, which wraps around the west side of the city of St. Louis. So here's city of St. Louis in yellow, and then this county right here is St. Louis County. A little bit about our community. About 2/3 of our residents are white, another 25% are Black or African American, 5% are Asian, and 3.5% are Hispanic or Latino. And then the median household income is about $72,000, which is similar to the median household income for both Missouri and the United States overall. So my role with the Department of Public Health, I'm part of the Chronic Disease Epidemiology Program. Our program is responsible for chronic disease surveillance, and we cover a range of chronic disease topics, including environmental health and respiratory diseases, which are some of my main areas and the focus of this presentation. Our team follows a similar process for each report that we publish. We usually receive data from the state each year, usually in the fall, and then these data are often on a couple-year lag and include death records, birth records, hospitalizations, and emergency department encounters. We also receive data from our local medical examiner's office and from our environmental health lab. The first step after we receive data is often to conduct a series of analyses from which we can start to identify patterns, select messages to highlight, and create visuals that will all go into a report. And before a report is published, we often reach out to partners. These may be external partners, such as university researchers or local nonprofit organizations. And then we also contact internal partners, such as other teams within our department who are working in that area. From there, we incorporate any feedback into a finalized version of the report that is then shared with our community, usually along with paired content on social media to promote chronic disease awareness. While updating chronic disease reports is a key function of our team, new updates to reports often confirm what is already known about a disease's distribution and disparities that exist within our community. So a lot of times we make the same map and they all look very, very similar. One goal with the most recent update to the asthma report was to include data that were more actionable. And so to do this, I focused on expanding what had been a kind of brief section in the last report on environmental risk factors and focused on pairing that data with asthma emergency department discharges, which account for the most asthma cases in our data. And instead of reaching out to partners towards the end of the report writing process, I was in contact with several partners throughout the entire process, from report conceptualization to finalizing and sharing the draft. We identified 2 key partners within the Department of Public Health whose work was related to the focus of this report. The first was the Environmental Health Lab, and they collect and analyze and report daily pollen and mold counts for the county. And they provided the pollen and mold data that were featured in the report and helped us to understand how these data were collected and analyzed. The second team we identified was the Healthy Homes Program, and they provide in-home assessments to identify asthma triggers. They also offer family consultations and asthma management and education programs. We met with their team during the report development and writing process to inform the risk factors that were analyzed in this report and to receive feedback on our findings. So we generally apply 2 ways of looking at the environmental health data that we have available with our asthma data. The first, we can compare trends over time. For most of our outdoor environmental data, there's a set of daily records that are applicable for the entire county. In the report, these data were paired with daily counts of emergency department discharges for the entire county. As you can see in these figures, in the first half of the year, the average number of asthma emergency department discharges per day corresponds with the months in which there were higher daily pollen grain counts. So while this is not the full story, it does give us a clue as to what's happening with people who have asthma during the spring. The next thing we can do is compare trends across geographic regions. In contrast with the outdoor air data, most of the data we have about households in St. Louis County comes from the American Community Survey, which we can use to look at trends by census tract, zip code, or county region. And these data are more granular in terms of geography, but we have less day-to-day detail. Still, it's a challenge to really extrapolate what's happening across the county. From this map, you can see that there is a much higher rate of asthma emergency department discharges in the northern part of our county. But I still, I don't know the exact prevalence of asthma by zip code. And I can't really tell if this trend is due to more people with asthma living in North County, or whether people with asthma in North County experience greater barriers in managing their asthma, be it greater exposure to asthma triggers, or due to heightened barriers in accessing asthma treatment. I imagine it's a combination of those. And then here we can see the county regions that our team uses in addition to zip codes and census tracts. I'll be referencing these throughout the rest of the presentation. So for geographic data that are difficult to show, by zip code or census tract, we use rates and other indicators broken down by region. to get a better idea of what might be contributing to higher rates of asthma in these two areas. These regions were defined by the St. Louis County Department of Planning based on shared social and economic characteristics. And in the map, the highest rates of asthma emergency department discharges are in the region labeled inner north and outer north. And I just want to add a note on the central region. I'm not going to go into the details, but the central region is often an anomaly in these data. And this is just due to some unique characteristics of the region. It's generally wealthier than the rest of the county and includes the Washington University campus. And so there's a large student population in the area as well. The one known risk factor for asthma with data that we did have access to was proximity to vehicle traffic. Emissions from cars produce air pollution and is known to increase the risk of developing asthma. And the Missouri Department of Transportation provided traffic volume data for roadways in St. Louis County. I defined high volume or busy roadways as road segments with more than 10,000 cars per day. And what we can see from this data is that there's not a real strong relationship between proximity to busy roadways and asthma. Each region, they're not all that different from each other, but the central region, where we do have quite a bit of traffic, has some of the lowest rates of asthma in the county. And the inner north and outer north regions were second and third in terms of populations living near busy roadways. Next, I wanted to check whether there was any relationship with housing stock age. While there was a large variety within housing by age, older houses are more likely to have poor ventilation and insulation, which increases the risk of indoor moisture and growth. And the greatest proportion of older housing stock was located again within the central region. However, there was a large proportion of older housing in the inner north and outer north regions, particularly among houses built between 1940 and 1979. The third indicator we have available to help us understand potential asthma risk across our community is renter-occupied housing units. As with housing stock, there's also variation in the quality of housing across renter-occupied units. Nevertheless, common asthma triggers such as secondhand smoke, mold or moisture problems, and pests are more common in renter-occupied housing. In addition, children with asthma are more likely to live in a renter-occupied housing unit. And this is where we see the greatest correlation with distribution of asthma emergency department discharges. And then again, just to show you where these regions are, the inner north and outer north region are highlighted in yellow and red. And the inner north region in particular has a greater proportion of renter-occupied housing units. These regions are also where we see a disproportionately high rate of people needing emergency care for asthma. And so by working with the Healthy Homes team during the report writing process, we were able to share these findings with them before finalizing and publishing the report. So in addition to helping me to understand some of the experiences of people with asthma in our community, which as an epidemiologist, I don't always have the opportunity to do, our working together helped their team make decisions about a new program they were setting up. So earlier this year, the Healthy Homes program was awarded a 3-year, $1.8 million grant from the Department of Housing and Urban Development for the Show Me Missouri Healthy Homes program. The program, which is implemented in partnership with Children's Mercy Kansas City on the other side of the state, supports assessments and remediation in 135 residential homes in targeted communities in St. Louis and Kansas City. The goals of the program are to improve family health and safety through home assessment and remediation, increase the number of health professionals with knowledge of healthy homes issues through Building Performance Institute courses, and improve knowledge of safe and healthy home issues for residents through structured education and outreach workshops. In St. Louis, the Show Me Missouri Healthy Homes program is targeted in the Promise Zone, which spans both St. Louis County and the city of St. Louis. The area covers 27 municipalities in the county, located in the inner north and outer north regions, which you can see here on the map. And as indicated by our asthma surveillance, members of our community living in this area have the greatest burden of asthma and relatively high rates of exposure to known risk factors. In particular, the prevalence of older housing stock and high proportion of renter-occupied housing units suggest that the Healthy Homes interventions can have a large impact on improving asthma management for people with asthma in these regions. And looking at the map of asthma emergency department discharges by zip code, the parts of the St. Louis chromosome located in the county, which are highlighted in red, cover many of the zip codes with the highest asthma burden. However, it does not entirely match up with a specific region or all the zip codes with the most asthma emergency department discharges. When we pair these data with the zip codes with a higher proportion of renter-occupied housing units, the areas do match up pretty well. So some next steps for our team, we are working to expand our asthma surveillance program through the utilization of new data sources, including Essence for more timely asthma emergency department encounters, and are actively looking into new sources for identifying risk factors such as 311 call data. We're working to increase accessibility of these data through the development of interactive dashboards. And this year, our team received support through the Council of State and Territorial Epidemiologists Data Science Team Training Program to create and implement an asthma risk prediction and warning system that is based on daily levels of known outdoor environmental risk factors. Once complete, the warning system will alert people with asthma of days in which they may need to take extra care to prevent an asthma attack. And then finally, we're working to partner with school nurses at local public school districts in order to better understand and respond to the needs of children with asthma in our community. If anyone has any specific questions or would like to talk more, please feel free to reach out via email. Thank you.
Thank you, Ellen. That was a great presentation. I loved, seeing all the different analysis that you did. It was great hearing how the, partnership between you and the Healthy Homes team, both benefited you both, by partnering early like that in the report process. It was great. Now, I would like to transition us to the panel discussion and question and answer session. So I'm going to invite all the speakers to come back on camera. And I would also like to introduce Kate Hastings. She's an EPA contractor and will be the facilitator for our panel discussion today. So welcome, Kate, and you can take it away.
Thank you, Mary Jo, and thank you, panelists. That was terrific to listen to all of you. And one of my first thoughts as I listened to you all was, wouldn't it be incredible if they were describing one community right now, right? If we had this data from all these levels describing one community instead of several different communities, and what could you all do together if you all had this data in the same community? What kind of advocacy and action you might take with it? Another thing I found really interesting and just want to reflect back to you was that as I heard you talking, I heard how the different levels at which you're collecting data to inform your understanding of where is asthma risk driven by environmental exposures, particularly indoor exposures, was how the different levels of data help each of you understand the asthma problem in the community. Ellen, I was particularly taken as you were talking about partnering with your Healthy Homes program throughout your process. And when you said, as an epidemiologist, it really helped me to hear from people who go into homes with Healthy Homes visiting and do asthma education to contextualize the asthma experience. And I'm sure for your Healthy Homes partners, it was so helpful for them to understand how all the outdoor sources of risk both vary seasonally and how they get into, as you were saying, leaky substandard homes. It was just very interesting to hear and think about what might this group of people be able to do if they were to stack up all this data. Also, I want to reflect for you some of what we heard in the chat. First of all, it was great excitement, particularly about Red Hook, the engagement from the citizens, the community-based science. I loved, Carolyn, what you said. What was it that you said specifically? It was about the educated hypotheses and then being able to test those educated hypotheses that are informed by real citizen experience. Lots of folks in the chat also reflected the same. One of the topics came up in the chat, came up among all of our panel as we prepared for this webinar, and that was you're all saying that from at different levels, you're recognizing air exposures specifically causing asthma problems. How do we get air cleaners or air purifiers paid for as healthcare? I just want to say that came in the chat. I know you all have also talked about this. Carolyn and Kara, I wonder if we could talk for just a second about your experience both with air purifiers and air cleaners being used indoors in Red Hook and your interest in getting more of them. Can you share with us just a little bit about what you've learned, what you're thinking, and what you wish you had so you could go advance that let's get paid for our air purifiers? What data maybe would help you get there?
Yeah, I'm happy to start. So last year when we did 50 air purifiers to Red Hook residents, that was like it was a small pool of funding. So IKEA is in the neighborhood and we were like, hey, IKEA, you have air purifiers. Can you go on this with us? So we partnered with them. And honestly, we just recently surveyed and had conversations with the families who got those air purifiers to see like, how's it going? What's working. I think one learning that came up for us was like having to replace the filters is a burden for a lot of folks. So as we're like talking with the housing authority now about like, what if we had air purifiers in every bedroom, every living space, like thinking about the sustainability of that for folks is really important. I don't have an answer for that. But also like, I think too, another piece of this is like making sure that, especially with public housing, okay, say we get air purifiers in every apartment, that's not a reason to stop like remediation work on mold and other things in the apartment. That's gonna be huge. And of course, like the housing authority recognizes that with us, but it's like, I think that's just like a challenge too. But then a piece to this is like, quite frankly, it's the funding around it. And our plan is to like shop the proposal around. That's what we're working with, which is hard, but that's the reality of this work. Like as we're trying to do like a lot of emergency response, it's like piecing together funding, which is exhausting. But that's like, at least in Red Hook, that's how we're making it work.
Yeah, and just to add to what Kara said, I really got interested. Well, let me go back. Originally, I do outdoor air monitoring, where I learned these skills up at CUNY. However, when I found out about Kara's plot program, I thought it would be very useful. For the simple fact that because Red Hook is a environmental justice neighborhood and they are currently under construction, I found it really odd that when the residents complained about having mold and lead dust paint in their apartments, NYCHA would tell them to simply open their windows so that they can get cross ventilation. And that didn't really make sense if they're under construction. And that dirt or soil, as you would want to call it, has lead in it, that you're telling people to open their windows. So it's like you're doing things to exacerbate the condition of asthma. And so I decided that this was a really good idea. I went to a town hall that was hosted by Mayor, what is his name? Yeah, I thought that was Mayor Adams, and asked him what could he possibly do, him and his office, what could they possibly do in the next 30 to 60 days to improve the air quality in the NYCHA development at Red Hook, and basically he said nothing. He didn't offer like, maybe in 120 days I could do something. He just was outright saying no. So then NYCHA employees came up to us and they were like, let's talk, let's see what we could do, because we do have a high asthma rate in the public housing developments, and we would like to partner and do something about it. So this is just a way to expand on the marvelous work that and thoughtful work that Carrie started.
It's great, Carolyn. Thank you. And Kara, thank you. And I wonder, Adam and Liz, I'm thinking about one of the takeaways from your presentation, specifically around proactive rental inspection and how the kind of EHR available data you used might help feed a proactive rental inspection regime, and how that could eventually be partnered with public housing and like the density and rental data that Ellen was shining a light on to actually create a potential system to move us towards solutions. Can you talk a little bit more about that? Because I know folks in our audience would love to hear a little more.
Yeah. Okay. I mean, I think one of the things we've envisioned is, could these data feed into like a dashboard of some type with community partners or housing agencies or whomever that could direct proactive inspections, to see if there's home remediations. Another thing we talked about is that you're working with, actually there are a fair number of insurance payers or health systems that do have home visitation programs specifically for controlling asthma triggers. Could you use this to direct those home visiting programs? A lot of them rely on physician referral, which is really great and really important and should still happen. This isn't meant to supplant that. But in the event that, they don't receive a referral from the emergency department or from a primary care provider's office for these more like these home visitation programs to address, not only identify triggers in the home, but also to address structural problem and damage in the home, mold, air quality, et cetera. They could be used to direct some of those programs as well. And those are some of the things we were looking at and trying to test. It's great that the ED visits correlate, they identify poor quality housing accurately, and that we can see they go up earlier, but can they be used to actually, target interventions and services? And then does that improve people's health? That's, I think, the kind of real life application. That's like the next stage of figuring out how these data can be utilized. Sorry, Adam. Add anything?
Sure. I'll just add that generally in American jurisdictions, there is a housing code that provides a legal minimum standard of housing quality. But the reality is that for a lot of people, that's just not, that a lot of houses are not up to code. And there's a lot of landlords collecting rent checks, despite the fact that people are living under conditions that are making them really sick. And that's something that we know. And so there's a question about like, what can we do to change that? And I guess we think there are two pieces that Liz talked about. And one piece is like stronger enforcement. And if there's actually data that like this particular house has an asthma rate that's 10 times its neighbors, that's important. And that's important for the city to do something about like immediately. And the other piece is that there are residents who are typically know about these conditions, like, because that's the lives that they're living, right? That's their experience. And so we're hopeful that these type of data can support their advocacy and their organizing. In the case that motivated our study, there was a battle between the tenants and the landlord after the conditions were so bad that HUD had to close the complex down. And the landlord argued that people were sick just, because, nothing to do with the housing, basically. When we look at the data and we see that particular complex is the worst in the city, it's harder to make that type of argument. And it's much easier to support the organizing of tenants. So that's sort of what we hope this could be used for.
There is a lot of great activity in the chat as folks are listening to this conversation. People are, and I encourage all of our panelists to look at the chat afterward. There's a lot in there right now, but folks are talking, as I'm sure, as you just sort of brought up, Adam, folks are talking in the chat about standards for housing, about linking standards for housing to this data that's showing us housing is linked to health outcomes. I wonder, Ellen, I'm going to come back around to you because one of the things you talked about throughout your presentation was linking with other public health partners as you developed your report, and really thinking, as this whole webinar has been about, of how do we make sure whatever level we have data, that data is meaningfully reflecting the real experience of asthma, and where we might have opportunity to intervene where the environment is driving that experience. I wonder, Ellen, if you can tell us a little bit about the Healthy Homes program. I think what you were saying, and I want to make sure I'm getting this right and reflecting it for our audience, is that you could see from these different levels of data that they're pointing toward an area where you have a lot of renters, a fair amount of density, some old housing that's very likely letting outdoor air in, and you could tell us something about that outdoor contaminants. Do you know what the Healthy Housing program might be prioritizing for asthma specifically? Do you know what they might be thinking to move toward? Are they going to use your data, do you know, to say, let's advertise the availability of asthma home visits in these areas, for example? I'm trying to think of solutions for, short of getting Medicaid to pay, which there's a bunch of conversation in the chat about how do we immediately go to health payments for home improvements. I'm just wondering what's actionable that we can do right now with partners we have. And so I'm thinking back to your development of the Healthy Homes Partnership and what they may have learned and might be thinking about doing based on some public health partnerships that already exist.
Yeah, I mean, I can't speak to exactly what the Healthy Homes team is doing in that area. They are targeting that promise zone for this grant program, and they're really focusing in on that area. And kind of, so a little bit of what has been discussed, the grant does provide for remediation in homes. So that's going to be addressing mold and moisture problems, poor ventilation, stuff like that. It's just kind of, people have to meet certain criteria to qualify, and living in that area is one of them. And I would say that it's a challenge from my end, just because we don't have that granularity that is kind of shown in the other presentations. With I can look at the census tract level, I can look at zip codes, I can kind of merge that into a region. But I don't know specifically parcels, housing units. And so, something that I would love to do moving forward is, find a way to access those kind of data, which might be working, with the specific hospitals to get some kind of agreement, which, from a health department is challenging because, you have to have, those negotiations, you have to get the data sharing. But something like that would be really awesome to kind of help better guide programs and really focus in on those areas.
That's great, Ellen, and I'm sure you can see your colleagues on the panel nodding. Liz, I wonder if I can invite you in on this topic. I think you have some thoughts to share too.
Yeah, so as a physician, in general, we know social and structural determinants of health is the largest driver of health outcomes and health inequities. And to varying degrees, health systems are, in some respects, being held accountable for them, but we don't hold these social and structural determinants or social services to the health outcomes that they produce, right? I can't see the chat, I can't wait to see it, but I heard you say that people were talking about this. I think this is absolutely true. So if we have public services for people, how we measure the quality of those services, or do or don't measure them, health outcomes related to what conditions or services they provide is something that I think is largely underdeveloped, but I think is really important if we're talking about the well-being of people who utilize and reside in those services, and housing being like a really key part of that. It really, they're so, we know they're closely related. We don't use them to measure quality of the services that are provided. And I think to varying degrees, all of our presentations utilized healthcare utilization data, right? That can be operationalized now. There are other things to do for more nuance and parcel level and all those things, but largely it is something I think that's people need to maybe set up the infrastructure, but it's something that can be done.
On that note, I'm going to turn it back to Mary Jo, and I just want to reflect back to those in the chat who are saying, what are the key drivers of housing quality driving health? Why isn't the EPA doing something about this? The EPA is doing something about this. The EPA is hosting this webinar right now. The EPA is talking and looking for everything the EPA can find on what sources of data, citizen data, publicly available data, EHR data, getting in and partnering with health system data. But what data can we leverage and put to work right away to reveal more about where we know environments are driving health outcomes? And this topic today, indoor environmental determinants of health and solutions in asthma, is specifically representing a whole program area and initiative that the Indoor Environments Division is leading to do exactly what we're all calling for, which is help us all understand which exposures are contributing most and where and how can we most readily act on them. So everyone in the chat, you're 100% right. That is what we should all be doing. And that's what we're talking about now and why. This is a complicated question and there aren't simple answers, which is why we don't already have a standard and we don't have all the data. But it's just really exciting. And I thank so much the citizens, scholars, leaders, public servants, and everyone else involved in this panel today. It's been very exciting. All the panelists will make sure you get the full chat and can see everything. And Mary Jo, thank you so much for giving me a minute to talk with this great panel today and for hosting us. Thank you to EPA.
And thank you, Kate, and thanks again to all the panelists today. Yeah, I just want to emphasize that I think all of our panelists showed that no matter what type of data you have access to, you can do something with it. You know, and no matter what type of organization you are, what type of level you're working at, there's definitely action that you could take today with this type of data. And this just also shows, you know, the potential for partnerships, you know, across different sectors. And yeah, as Kate said, how amazing it would be if all these panelists were working in the same community, you know, what they could achieve. So thank you again for that, you know, wonderful panel discussion. And so now as we wrap up, Pierce, you could go to the poll. I would like to ask our audience to please take a minute to revisit this poll to help us assess if we are meeting our goals to support learning and action on using data to prioritize in-home environmental interventions. So as a group, do we feel more ready to use data and analytics to inform community action to address IEDOH and asthma after listening to the 3 stories we heard today? So I'll give it another moment. All right, Pierce, can we see the results of that poll? Thank you, Pierce. Well, that is great to see. It looks like we've all moved to be somewhat more familiar with using data and analytics to prioritize interventions. That is great to see. So I want to remind everyone that on AsthmaCommunityNetwork.org, you will find recorded webinars, including this one once we post it, and others such as our webinar featuring US EPA's 2023 winner of the National Environmental Leadership Award in Asthma Management, Wisconsin Department of Health Services Asthma Program. By joining the network, you can also make sure to hear about the next webinar we'll host in the series on solving for the IEDOH and asthma when it is announced, as well as a wealth of resources. On Asthma Community Network, you will also find information about our awards program and how to apply. Each year, we recognize successful programs that have implemented innovative approaches to providing comprehensive asthma care. This award is our way of not only spotlighting programs that deliver excellent environmental management of asthma in their communities, but also to share their successful approaches with others to rapidly spread these best practices. The application process will be opening soon, and we encourage eligible programs to apply. EPA's learning objective for this webinar series is to equip communities and asthma programs with the knowledge, examples, and insights they need to put into place comprehensive asthma care systems that address the IEDOH. This is our objective because we know that when those systems exist, we can deliver on the vision that we know is possible, where barriers to accessing environmental asthma home visits are eliminated and the lives of all people with asthma are improved. Though each community strategies may look different and different mechanisms for payments, workforce, data, and delivery will emerge, each suited to their unique policy landscape and asthma burden, we know there are common strategies that work for building, getting results with, and sustaining comprehensive asthma care systems. And we at EPA IED are here to help every community nationwide to take them. Thank you. And thank you again to all our speakers and panelists. That was wonderful. And thank you all again to our audience. Have a great day.